Hello, I'm Dr. Jambi Mathenge here with Fits on the Go, and here with me today is Dr. Michelle Albert. Dr. Albert, welcome to Fits on the Go.
Thank you so much. I'm so happy to be here. Now, the question is, sort of how do we address this, and what are some of the factors that go into this? Like everything else, it's multi-layered, and we have to look at the risk factors as well as behaviors and then interventions. And solutions, sort of encompass all of those things. So I think what I'd like to highlight are a few unique risk factors. So we all know the traditional risk factors, and for the most part, things like hypertension and obesity have a much higher prevalence in African Americans than in other, and actually in the African diaspora period across the world than in other racial or ethnic groups. With some exceptions, as it relates to diabetes, for example, in American Indians, as one example. However, I want to address things like stress, psychological stress. Psychological stress is something that is subjective and is perceived typically, but we know that the chronic and cumulative effects of stress over time have major potential impact on cardiovascular disease risk. And certainly there's research that we're doing currently at UCSF in my group at the Nurture Center, where we have observed that there are significant differences in cumulative stress by race and ethnicity. And we know that, for example, unemployment rates are typically twice in African American communities than there are in other communities. There are issues related to, sort of justice, it's a social justice issue in essence, food insecurity, to name a few items. Also, beyond stress, another unique item I would say is African Americans, have, there's sickle cell anemia is a unique risk. There are 100,000 African Americans with sickle cell disease. There are also parts of the Asian diaspora with sickle cell disease and parts of the Arab diaspora that have sickle cell disease. And we know that sickle cell disease is associated with heightened cardiovascular risk. What we know less about is carrying the sickle cell trait. What is its relationship with cardiovascular disease? So I think we do need more research in that realm to understand the elevated risks. I think another factor that we don't talk as much about in our community is that approximately 1.4 to 1.5 million African American, 1.4 to 1.5 million individuals in the United States have HIV. Among those, about 40% are African American. Although HIV has become a chronic illness, HIV itself is an inflammatory condition. In becoming a chronic illness, cardiovascular disease risk is heightened. And some of the therapies used, and appropriately used and should continue to be used for treatment of HIV can sort of have untoward effects on blood pressure, have untoward effects on dyslipidemia, for example. And so these are things we need to make sure we turn our attention to and pay close attention to in terms of interactive effects related to risk. Other factors include social factors and social determinants of health, which are incredibly important, particularly as they relate to the obesity epidemic, as they relate to adherence to medications and adherence to health guidelines. With regards to solutions, the solutions have to be multifold. Being someone who is in academic medicine, I think one of the solutions is actually our workforce and improving our workforce in healthcare and in allied healthcare fields that focus on the health and well-being of our populations. I think having the lived experience really, or understanding the lived experience as well, has a huge impact on measures used to treat disease processes in, for example, African American community. We know that, for example, for obesity, that although there are, sort of interventions for obesity, that these interventions don't aren't sustained long term and are less effective in African American communities. And so taking a look at why they might be less effective and designing intervention studies that incorporate social determinants of health and other factors that specifically affect the community might help to sort of shift the compass somewhat and develop new hypotheses about how you treat things. So I think workforce is important. Another issue would be access to healthcare. And making healthcare equitable across groups. For example, let's say only about a third of cardiologists feel that there are disparities in healthcare, and only about 5% of cardiologists feel that they have disparities in their practice. So elevating the knowledge and the sources of disparities becomes really important in the population, because the delivery of healthcare is affected by that, and the access of individuals across various racial ethnic groups, especially vulnerable populations, is affected by on lack of understanding and related to disparities. I think having insurance access that is equitable, employment access, I think that is equitable. I actually happen to personally believe that the issue of employment is a really, really critical one, as I mentioned before. When you have populations that are underemployed or unemployed, then you don't have then adequate access to education, and kids don't have adequate access to education or an advantaged education that would allow the health and well-being of the community. So I really think that that's a fundamental issue. So workforce, healthcare access, insurance, research. We know that inclusion of minorities in clinical trials, all types of minorities in this case, has been lacking. There have been lots of efforts to, sort of promote inclusion, and I think those efforts should continue. But I think again they have to continue with taking into account the diverse backgrounds and diverse thoughts about what is appropriate science. And what might be appropriate interventions to put forward. There's a precision medicine focus currently that's primarily omics and genetics focused, and I believe that sort of precision medicine should encompass population public health as well, as part of its translational look. In order to address gaps in healthcare and also to address success of our medical interventions going forward. Because, in one sense, at least certainly to me, it doesn't make much sense thinking only about sort of genes and sort of how we might personalize something for an individual when the individual doesn't have access to the care and can't sustain the care. And I think, as we know in terms of the statistics, despite the advances in care, there are still huge gaps, and well-being and poorer health may be worsening in those populations, such as African Americans, where we've had issues in the past. And so we just have to be very careful as we move forward in our science, and we should move forward with our innovations related to precision medicine, but we have to be careful that it does not exacerbate disparities at the population level and even at the individual level. I think is a big challenge potentially going forward. Additionally, I think that our community, the African American community, has to take a look at itself and be active participants in our healthcare, and sort of view our healthcare as critically important to advancement on a larger level. Because if we're not, sort of participant, then we can't expect others to want to see us, survive and be successful. I fully understand the factors that go into preventing us from, achieving certain behavioral and other healthy activities, such as having unsafe neighborhoods, etc. But this is a huge problem. I think that we know that socioeconomic status plays a major impact in health. But I think one thing that's really, really important to note is that even blacks who are more socially advantaged do worse off in terms of their health care, in terms of employment, than whites at the same level and other groups at the same level. So these issues are, sort of systematic, and we're all in it together, and need to, sort of put our minds together on this.
Thank you very much, Dr. Albert. And for more videos like this, follow us at youtube.com/FITSontheGO.